So, Dr. Wright, thank you very much for joining us this morning.
So today I want to talk, as per the title, MRI and ischemic heart disease. I felt I needed to narrow this subject a little bit, given its breadth. We're focusing on a subject we've been looking at in the lab now for about the past 5 years, particularly using MRI to look at myocardial injury response after an acute myocardial infarction. Now, as I think we all know, acute myocardial infarction or heart attack, the most important thing if one is suffering a heart attack is to get revascularized as early as possible. As the saying goes, time is tissue. And what these images kind of reflect is that as time goes on, you get more and more damage to the myocardium, which is this dark ring in an MRI image. But even depending on the time of getting revascularized, different people will end up with different types of injury based on various circumstances which we don't very well understand. And particularly after you revascularized, there's an issue of how that damage will progress, for instance, towards heart failure and the like. And obviously one of the real goals is to minimize the advance of that damage after you've dealt with the initial insult of acute myocardial infarction. And unfortunately, our understanding of what happens to the heart after that acute event is actually quite limited because it's very hard to track tissue in a living subject. In fact, probably the best data right now is associated with actually a fairly old study now of autopsy studies looking at autopsies on patients at various stages who passed away after an acute myocardial infarction. You do get, from those kind of studies, you do get a sense that there is various responses in the heart. It's a very active tissue after an ischemic insult. There will be cell swelling, there'll be inflammation, there may be hemorrhage, there might be microvascular obstruction, things associated, for instance, with what's so-called reperfusion injury. And in the long term, that may, obviously the edema goes away, that may lead to fibroblast proliferation, which will end up with a deposition of collagen, which tends to bring the bad downstream effects of thinning of the wall, for instance, seen here, and actually thickening of the remaining wall and enlargement of the remaining wall, which is termed adverse remodeling, which tends to be the beginning stages of progression towards heart failure, which ultimately could lead to the death of that individual. So one of the real challenges that we see is how do we better understand the mechanisms associated with this propagation of damage, and with a better understanding of the mechanisms, can we actually halt the prevention beyond just trying to revascularize the patient? So are there adjunctive therapies that might help out? And it turns out that MRI is actually a wonderful modality to help us in trying to look at this question. Because MRI is excellent in soft tissue contrast and gives us a real sense of what's going on in the tissue itself. So, for instance, MRI can look at cardiac function by looking at movies of the heart and the heart wall. And these are just different slices through a heart in the various short axis, and you can basically see the main chamber of the heart, the left ventricle, squeezing, and you can see how the wall thickens to pump the blood out. Beyond function, we can use, with the addition of a contrast agent, gadolinium, we can actually look at what tissue is dead and alive. So after we inject gadolinium, what we can do is set up a contrast in MRI where healthy tissue, this is the muscle of the myocardium, is black, and then damaged tissue is bright. And in some circumstances, if there's a core of darkness in the middle of that brightness, that's where there might be microvascular obstruction, so where the agent can't arrive in. Beyond that, there's another tissue contrast called T2, which is basically how fast the MR signal decays away, which can indicate water content. And that's very important if we're trying to understand inflammatory responses, as is one of the responses associated with the ischemic insult. And so what that looks like in an MR image that is, quote, T2 weighted, is a bright area. And so that suggests that this area of tissue after the acute ischemic insult has now become inflamed and it has more fluid in it and is edematous. And finally, another thing that MR can look at with another contrast mechanism referred to as T2 star is areas where there might be iron deposition, which is messing up the magnetic field, and the T2 star is, again, a signal decay constant, which says how fast the signal goes away due to field disturbances. And so here you may see a darkened region due to the accumulation of hemorrhage in some cases. So MRI gives us this rich sense of what's going on in the tissue, and we can use that to look at over time as to how the tissue is evolving, how it's responding to the ischemic event, how it's trying to repair itself in terms of managing the damage that's occurred due to the ischemic insult. So obviously our goal is to understand the progression in a patient, but to better understand, first of all, the mechanisms, a good place to start is a good preclinical model. And so many of our studies began with an infarct model associated with a pig, which turns out to be a very good model of what's going on in the patient. And what you can see here is sort of different degrees of disease in patients associated with different times of ischemic injury, so those with kind of short ischemic events versus those with long ischemic events. And similarly in the pig, actually the pig's time scale is a little compressed. Basically, the time that we occlude the left anterior descending artery, if the longer we occlude it, the more damage we create. So these are just different degrees of occlusion and different amounts of damage, which parallel very well what's going on in the patient population. So obviously the first thing we can do with a preclinical model such as a pig is get a good sense of what are those MR signals really reflecting what I said they were reflecting. And so in this slide you can see images that, such as the ones I just described before, and histology. And you can look at the histology and say, yeah, well that's the infarct zone in an H&E stain, which corresponds really well to that region of brightness on the gadolinium enhanced image, so demonstrating the viability issues. Similarly, we can look in regions of elevated T2. Remember, that's our indication of water. And you can see that in those tissue regions, you get a lot of fluid in the interstitial spaces, so reflecting the edematous response. And finally, in regions where there might be significant signal loss associated with the T2 star decay, so those dark regions, those are regions where indeed there is hemorrhage, where you can see red blood cells accumulating in the tissue and later on iron deposits associated with the cleanup of that. And essentially, in this animal model, we repeated that study on autopsy by looking at histology at various stages. And we see very similar behavior as was seen in those autopsy studies, where you get this initial edematous response and inflammatory response, and then this buildup of fibroblasts and ultimately the deposition of collagen, which leads to this adverse remodeling. So we think we've got a good model, and we have that reflects what the autopsy studies showed in patients. So now, can the MRI tell us, show those same kind of evolution, and maybe give us some more insights as to what's going on in the damage, which might give us opportunities to find new adjunctive therapies. So what these images are two different animals, one with a relatively mild ischemic infarct, the 45-minute infarct, versus one with a severe infarct, the 90-minute infarct. And in this delayed gadolinium-enhanced image, you can see the classic bright rim of non-viable tissue with a core of microvascular obstruction, indicative of a severe infarct. We can also look at what's going on in a remote territory away from that, and I'll get more into that in a second. And you can see how in this case, this resolves at least over 4 weeks. The microvascular obstruction resolves, and you end up with this transmural infarct, which of course is very damaging. That wall is pretty much gone and is going to turn into pretty much leather. And whereas in a 45-minute infarct, the less severe infarct, you get a much smaller region of non-viable tissue, non-transmural, so actually that heart is still going to function quite well. So certainly it's reflecting the characteristics that we mentioned before. And if we look at these measures of edema and hemorrhage, again, in the situation of severe infarct, we see this bright elevated T2, which suggests edema around the region of the infarct. So there's a lot of swelling going on. And similarly, in the T2 star map, we see these dark regions suggested of hemorrhage, which is potentially a bad sign. And whereas in the 45-minute infarct, we see a little bit of elevation, a little bit of acute inflammation, which resolves, and we don't see any of that hemorrhage. So again, we've got the signatures that we're looking for. So let's now use that and see if let's look over the time course from the acute situation to the chronic situation. So what's different between a severe infarct, which may lead to vascular remodeling and heart failure, and one which is not so severe, which patients will tend to recover from and not end up with this adverse remodeling? Well, we see a few interesting things. So this is a map of the T2 in the infarct zone, like remember, reflection of edema, versus time. And what you see is that fairly early on, you get that edematous response. And that edematous response remains over 4 to 6 weeks. So it's not just an acute edematous response, it turns into a chronic edematous response, a chronic inflammation, if you will, which seems to be more hazardous. It's interesting that even away from the infarct, in the so-called healthy tissue, you also see in these severe infarcts an edematous response. This is something interesting because remember that remodeling, that adverse remodeling and diastolic change in volume is actually something that's going on in the remote myocardium away from the infarct. So perhaps this is now giving us some insight that the fact that there does seem to be an edematous response in severe ischemic events, even in the remote zone, may be predictive of the damage going on in the remote zone. Whereas in those less severe infarcts, you do get an acute inflammatory response. The T2 elevates at the 1-week time point, but it resolves fairly quickly and is certainly gone by the 4-week time point. And the remote territory, you don't really see an edematous response. So again, perhaps more severe infarcts are associated with something going on in the remote territory. Also, what's going on with the hemorrhage? Again, remember that there was that microvascular obstruction in those severe infarcts, and we can look at that through this T2 star parameter. And basically, shorter T2 star reflects more hemorrhage and iron products. And again, you can see that those are there pretty much at the beginning of the ischemic event, and they do resolve over the course of about 3 weeks. So the heart does clean up that hemorrhage and iron deposition, so that by the time you get out to 4 weeks, it's usually pretty much gone. In the infarct territory, and of course there's nothing going on in the remote territory. Whereas in the 45-minute infarct, you really just don't see any hemorrhage, so that the T2 stars are pretty much constant. Now, if we look at the ejection function, so more a reflection of how the heart's pumping, we certainly see in the severe infarct that the ejection fraction is lower. It's pumping less because it's probably got more damage to the myocardium, but at least in this model, it's not changing much. But the interesting thing is that if you look at the end diastolic volume, what you see is in the less severe infarct, over time, the end diastolic volume pretty much stays the same, kind of a constant around 60 milliliters, in this case in the animals. Whereas in the animals with the severe infarct, you see that basically the heart's starting to expand. The end diastolic volume gets bigger and bigger over time, which is indicative of adverse remodeling, which is a precursor to full-blown heart failure. So obviously, there's a clear evidence that these animals are heading towards heart failure. So again, I think we've got this good picture, at least in the animal model, of various mechanisms and potential interactions between these mechanisms. So the next stage was, do we see the same thing in patients? So basically in parallel with the animal study, we started at Sunnybrook a study of patients that come in for STEMIs, ST segment elevation, myocardial infarctions, who are coming in for primary revascularization at Sunnybrook. Sunnybrook's the largest center in Toronto doing primary PCI for heart attacks. And so we actually have quite a patient flow in association with that. And so basically what we've been doing is within 1 to 2 days of the infarct and revascularization, we are able to do an MR image there, and then we get them back at about the 3 to 4 week time point, and then we get back at the 6 month time point. So we can actually see the evolution of the damage and associate that with various characteristics of those patients. These studies are all done on a GE-MR system, and we're looking at all the measurements that I've just described previously. So just to kind of put this in context, I want to give you just first of all a bit of an example of an individual who's part of the study. 73-year-old male. He had 4 hours of chest pain before he got in and revascularized. That's a fairly long time, and so you would expect a fairly severe damage to have occurred with 4 hours of chest pain. Certainly, he was brought to the hospital immediately because of the ST segment elevation, which is seen on the ECG, basically the elevation, the ST segment in the ECG. And upon arrival, they do basically a study to check if it's a large infarct, looking at the CK enzymes, and certainly this was. So what did this look like when they got him into the cath lab? Well, what you can very clearly see is here's his left anterior descending artery here, and essentially there's just a stub before they revascularized. And the amazing thing to me is you look at that and you say, well, I mean, there's nothing there, but they put in a wire blew up a balloon, and suddenly you've got this beautiful large vessel again resupplying the anterior territory. So certainly the sooner you can get that open, revascularized, the better for this patient. So the question is, well, they've now got a good result angiographically, they've got the vessel reopened, but what's happened to the tissue? What's going to happen to this individual? So looking at the 1 to 2 day time point on MRI, again, we can look at the wall motion, and these are slices, short axis slices through the ventricle, and you can see that the ventricle appears to be squeezing quite well. Sorry, I'm just trying to find my mouse. There it is. But if you look really carefully in the anterior segment of some of these middle images, you can see that while the wall is squeezing really well over here, it's actually not over here. So the wall is not thickening, which suggests that that wall is really non-functional. And if you look over into the gadolinium-enhanced images over here, you immediately see why. Essentially, this bright area in the myocardium corresponding to that region is essentially all damaged. You can see the bright area indicating non-viability, and you can see the dark core indicating microvascular obstruction. So very similar to those pig models, this is a big, severe infarct. And now the question is, what happens over time? Well, so again, we can look at the edematous response, and we can look at the hemorrhage at various time points, day 2, week 4, and 6 months in this individual. And what you see, first of all, is you see this elevated T2 in the infarct zone, these higher numbers suggestive of greater edema in that region, which slowly does resolve and by the 6-month time point has come down. But also there's this slight elevation in the remote territory, very similar to what we saw in the pig. So perhaps there's a slight edematous response going on in the remote territory as well. If we look at the hemorrhage map, again, you see this dark zone suggesting significant hemorrhage in that region of microvascular obstruction, which slowly does resolve, although there's still some evidence of it even out to the 6-month time point. And again, in the delayed enhancement images, you can see the microvascular obstruction, which certainly clears up by the 3 to 4 week time point, but this is all eventually resolving in a transmural infarct and a thinned wall. So this is a completely fibrotic wall, completely non-functional, obviously very problematic. And you may also get a sense that the heart may be slightly enlarging. So if we look over the patient population we've studied to date, we see overall in the injury region, which is the orange bars versus the healthy region, you certainly see the edematous response at day 2, which slowly comes down over the 6 months. There may be slight evidence of elevation in the remote territory at day 2, which is gone pretty much by week 3. In many cases, we see hemorrhage in the ischemic territory and the injury territory. And again, like the animals, the hemorrhage seems to resolve by about week 3, certainly by 6 months. The remote territory doesn't have any of that. And overall in this patient population, we did see an increase in end diastolic volume, suggesting progression to adverse remodeling. So we've got a bit of a sense of what's going on in this patient population. The question is now, can we break it down and look at specific mechanisms which might give us better indications of where we might be able to intervene and slow this progression towards heart failure? So one of the areas we've talked a fair bit about actually is hemorrhage. And certainly there's a number of studies out there now that suggest that hemorrhage is a frequent complication associated with these heart attacks, about 25 to 35% of STEMI patients, and that's roughly what we saw in our patient population. And it's been seen to be an independent predictor of adverse remodeling, again, that precursor to full-blown heart failure. So the question is this just an indicator, or might this actually be causal of that progression? And let's see if the MR can give us some insights into that. So if we look at the patients that we studied, and we break them down into the group that had hemorrhage and did not have hemorrhage, there's a few interesting things we see. For instance, in the group with hemorrhage, we see that elevation of T2 in the infarct territory basically remains over the first 3 weeks and actually even pushes out a little further than that, suggesting that this is not just an acute inflammatory response, this is a chronic inflammatory response. Versus those without hemorrhage, we see a more rapid resolution, a reduction in the T2, suggesting that perhaps there isn't as much of a chronic effect in the patients who don't have hemorrhage. So maybe the hemorrhage is being associated with more of a chronic effect. Similarly, remember in that remote territory, we see in the group with hemorrhage that elevation in T2 in the remote territory, slight but actually significant. Whereas in those without hemorrhage, we don't see that inflammatory reaction in the remote territory. So again, perhaps there's something in this that's suggestive of a target which might be addressable, which might be leading to adverse remodeling. So obviously one thing that's been targeted at hemorrhage and thrombus in general is thrombus aspiration. And this is not a randomized trial, this is just a registry study, so I can't claim too much from this, but if we look at the patients that got thrombus aspiration versus not in our study, we certainly see a trend. And those without thrombus aspiration, this individual is indicative. We certainly see a hemorrhagic indication, those dark zones on the T2 star map down here, and we see the microvascular obstruction, whereas those who got thrombus aspiration, we actually don't see the hemorrhage and we don't see the microvascular obstruction. So perhaps, again, there may be a role of this thrombus aspiration, particularly in those who would otherwise have had hemorrhage. And what happens to those patients? Certainly, again, this is indicative. Those who didn't get thrombus aspiration, at the 6-month time point, we see an enlargement of the heart, indicator of diastolic dysfunction. We see that transmural thin infarct, again, thin fibrosis, thin wall, which is, again, suggestive of progression towards adverse remodeling, whereas in those with thrombus aspiration, this is indicative of a smaller infarct, less damage overall. And again, if you look at the overall population, NTA is no thrombus aspiration. Again, at the acute phase, higher T2 indicating more edema than those with thrombus aspiration, lower T2 star indicating more hemorrhage, and in the 6-month time point, a larger volume and diastolic volume. So again, perhaps at least those patients with microvascular obstruction and hemorrhage may benefit from these thrombus aspiration approaches, and hence a motivation to go on and look at that in more detail. Another area of great interest and opportunity to study in this patient population is the role of diabetes. So what we did actually is take out all of those patients from our study with hemorrhage and only look at those without hemorrhage and ask in that population, did diabetes have an extra role in injury response? And we know that diabetes is associated with higher incidence of acute myocardial infarction and poor outcomes, but there's not a real good sense of exactly why. The specific mechanisms of the tissue response to ischemia are unclear, although there are some thoughts. For instance, we know that those with diabetes have poor have microvascular dysfunction, especially in the hypoglycemic states. And could that lead to greater edema, and could that chronic edema lead to worse outcomes? So we looked at that in the patient population, and again, here's an example of a patient with diabetes versus a person who didn't have diabetes. And if we look at the infarct territory again, and we look at the T2 indicator of edema, we see a higher T2 in that region indicating more edema in that region, and perhaps even a slightly elevated remote zone, whereas the T2 is elevated at the acute point, but not as much in the non-diabetic population. So again, if we look overall, here 16 patients with diabetes versus 36 without. At the early time point at day 2, we see a significant difference in the T2 in the ischemic territory, suggesting more edema in the diabetic population, and non-significant, but moving towards significance elevation in the remote territory in the diabetics versus the non-diabetics. So again, perhaps that edematous response is actually approaching being more systemic. We also see in the acute phase that the end diastolic wall thickness in the diabetics is actually thicker, which would also be suggestive of an inflammatory edematous response. There's more swelling in that region, so the wall gets thicker. Whereas at the 6-month time point, that same wall is actually thinner, suggesting that adverse remodeling, that wall thinning that you might see. So again, we're getting hints at something that might be specific to the diabetic population, which might be an addressable target. And if we look at predictors of acute myocardial edema in a multivariate study, it turns out, again, remember we've kept the hemorrhage out of this, that actually diabetes is actually the strongest indicator of acute myocardial edema after the heart attack, whereas symptom to balloon time is a second indicator in the multivariate analysis, whereas other elements such as age, door to balloon time, infarct size are actually not predictors of that edematous response. So again, more evidence suggesting that diabetes and that acute edema may be associated with why diabetics aren't doing so well. So diabetes is certainly an independent predictor of acute myocardial edema in these patients. This is consistent with many studies recently suggesting that diabetes has greater infarct size associated with those with hyperglycemia after AMI. And it gives a sense that perhaps that there is this ischemic reperfusion injury that is perhaps more important to consider in the diabetic patients. And that means that perhaps the diabetic patients should be a particular target of therapies aimed at reducing that edematous response, that inflammatory response. Perhaps that's a way to help them out. So again, I just want to kind of finish there. Essentially what I'm suggesting here is MRI is a very rich tool to be able to look at damage in the myocardium associated with ischemic heart disease, particularly associated with acute ischemic events. And perhaps it's going to help us better understand the underlying mechanisms associated with damage progression and point to potential new therapies. And particularly one of the things that we've really emphasized in the lab is the importance of quantitative MRI, so you can look across patients. So doing these actual measurements of these parameters like T2 and T2 star, which gives us more specific insight as to what's going on in the damages. And we're certainly seeing that using these tools, we see faster resolution of edema and earlier restoration of function in the less severe infarcts, whereas we see adverse remodeling in the more severe infarcts, which may actually give us insights into ways of addressing this. And certainly the preclinical models seem to reflect the same behaviors in the patients or similar behavior to the patients, and they will be an opportunity to actually explore the mechanism even more and explore adjunctive therapies in advance of clinical trials. And with that, again, thank you for your attention and thank these very many individuals, particularly Nilesh Gugre, who's a junior scientist in the lab, who's really been focused on the preclinical studies, and Mo Zia, who was a fellow and is now at Toronto East General, who's really led up the acute studies in association with many other colleagues at Sunnybrook and various other hospitals. Thank you.
Thank you very, very much, Graham. Presentation is open for discussion. Any questions for Dr. Wright?
So the remote injury that you've seen, so in the angiograms you showed there's more than one vessel of disease in it. So does the remote injury, particularly more severe, you're showing a 4 to 6 month prolongation of the animal model, does that prime for more severe damage for a second infarct in a distinct territory?
It's an interesting question, not one that we've explored in terms of secondary infarct. Obviously, there's a couple of things, I guess. First of all, in the animal model, obviously, the other vessel territories are fine because we create the injury in a specific region of the LAD. So obviously, you're seeing this remote injury independent of whether or not there's a good blood supply to that tissue. We didn't look in the patients specifically. Well, I guess we can look at the follow-up if they've had secondary events. But again, I think the more telling element here is really just progression to heart failure, really seeing that adverse remodeling, the thickening of the wall. And there's starting to become evidence, and we're starting to explore it, that MRI can also look at interstitial fibrosis, and perhaps more that remote injury is associated with kind of a mild inflammation, and you're starting to get interstitial fibrosis in that remote territory, which could obviously lead to the wall stiffening and diastolic dysfunction and so forth in association with progression to heart failure. So I don't know if it would also be associated with acute events in the remote territory.
Graham, I was wondering about your thoughts of mechanistically what links increased edema in patients with diabetes.
Yeah, well, I'm certainly not a diabetes expert, but I'm one of the, actually Kim Connolly at St. Mike's has been kind of our leading light on this, and he's given us some insights. But I mean, there's this sense of the osmotic pressure, and perhaps that's associated with kind of more leaky endothelial dysfunction, and perhaps there's also other damage to the endothelium associated with it. But I must defer to our colleagues who are. Yeah, so sorry, that's the T2 signal, but yeah, well, certainly that's the very clear evidence in the acute situation that there seems to be more acute myocardial edema in the patients with diabetes. Is there overall upon exertion? That's not a study we've done yet, but it's certainly a question we're looking into, and certainly there's we were starting to see some evidence. It's a study we're just putting out at ISMRM this year, where there's evidence, again, that the diastolic dysfunction may be associated with later stage interstitial fibrosis. And again, our theory is that the chronic edema is bringing in the fibroblasts, which is bringing the collagen deposition in that interstitial space. So there does seem to be at least an argument as to how the disease is progressing and associated with the edema.
Excellent. Well, thank you very